Okay, so it's 20 past and we said we would resume. Are we still recording or do we need to unpause? I can just see that the clock hasn't ticked on for the last.
We're still recording. The gap will be removed.
Thank you. So we're going to move now to the integrated performance report. And one of the good habits from COVID is that we're not inviting presentations of the report, but we're going to go to questions. But I've been alerted that Sarah has a minor correction to make to the paper in relation to emergency departments. So I'll perhaps ask her to do that first and take questions around ED after that, and then throw it open more widely. Sarah.
Thank you, Chair. It's just on page 48 of the IPR, which is under ED performance in the paragraph at the right-hand top of the page, third paragraph down. Overall ED attendances were 29% lower compared to January 21 to January 20. In fact, it's 33%. So apologies, we've made a mistake. It actually is 29% for February. So it's 33% lower attendances. So if we can just make an amendment for the minutes, I'll be most grateful. So apologies.
Thanks, Sarah. I wanted to ask about ED really, and I'm just finding it hard to get my head around the investment we've made, and we've heard about more of it today, which won't be in these figures, will it? Because it'll take time to come through, and the reductions in emergency department attendance, and it still seems that the 4-hour target fluctuates enormously, and we struggle with. And I appreciate, from the data we put together, it's obviously not unique to us, but there does seem quite a lot of variation, and I'd just like to know what we understand about that, and whether the things that you're putting in place you feel are going to sort it, or whether there's something about this which is always going to fluctuate. So grateful for a bit of clarity on that in my mind.
Yeah, so if I make a start, and then perhaps I invite Sam to come in as well to talk more about the system as well as what we're doing across the organisation. So in terms of ED performance for January, we see that it dropped to 71%. What I can say for February, it has improved overall in the month to 81%, so we've seen a 10% improvement. But you're quite right. What we've seen is that's quite a significant fluctuation in performance through the course of January. And actually, for colleagues perhaps who aren't aware, we actually, the EAU, the Emergency Assessment Unit, which is co-located to our emergency department at the John Radcliffe, actually was looking after respiratory patients for high care through January. So they didn't have direct access into our assessment area, which was really quite difficult for them. Also, we had redesignated a number of medical wards to receive our COVID patients and also non-COVID patients. So that fluctuation of capacity also didn't help as well, even though the attendances, as you quite rightly pointed out, have been lower and continue to be lower into February. So, but we have seen a change in performance in February, where EAU has come back online mid-February. We've also working with the emergency department and division and wider divisions and really looking back and restoring that ED performance. So they've set up an emergency improvement group. And they're refocusing on ED performance and also looking at what the rest of the whole division can support and help as we're restoring our wards to what they were pre-COVID of the second wave. So we actually have seen improved performance into March. So actually the first week, the first 7 days, and the last 7 days have been over 80%, and 3 days have been sitting at 90%. So we have started to see a sustained improvement, but we're looking at that improvement plan. I'll pass on to Sam. She might want to add some more into that.
Sam.
Yeah, I'm not sure there's a great deal to add. As Sarah said, this is about flow, and we stopped the flow out of A&E internally with emergency assessment, which was the right thing to do for our critical care patients. And I think particularly from Bruno's level, we're re-energising that system flow piece. We've been very focused on COVID. And Bruno, the Chief Executive of Oxford Health, Chief Executive of the CCG and of the County Council, are reaffirming governance and grip and control around our performance, which we're mirroring internally, with Sarah's deputy taking a lead on the improvements that we need to make operationally from the emergency department perspective.
Thanks, Sam. Is there anything else on the ED issues before I move to the question Paul has put in the chat? So I'm going to read this one out so that Paula doesn't share her building works with us, because she's suffering a disadvantage today and listening in on this. So this relates to pages 43 and 44 of the IPR, which is in relation to incident breakdown. And Paul has asked what message we should take away from this and what we learn for future patient care. Tony, did you want to add a question on that, or is it, can I put you in the queue?
I think you can put me in the queue, Jonathan. My question may be answered, in which case, of course, I'll take my hand down.
Great. So, Meghana.
Thank you, Chair. So if I could just start with, so I think Katie had a question as well about the incident. So looking at the series that have been declared in December and January, we will notice that the numbers are 30, the 2 months taken together, 13 and 17 each. The first thing to say is 15 of those are nosocomial COVID infections. And at the time of reporting, we were declaring each of these nosocomial COVID probable and definite as a separate series. Since then, having discussed it with Steve Powis at the Shelford call, they have advised us, the national team has advised us to investigate this as a bundle together as one series. So we will do that going forward. So that actually means across December and January, we have 15 series, which is more the average for the last 18 months to 2 years that we've had in the organization. The analysis on page 43 and 44 of the IPR shows is in response to a query and discussion from Sarah Horden at IAC last month, which is really to explore how these COVID-19 patients that we've had in the organization have been affected with regard to pressure ulcers and falls, and what is the incident reporting within that cohort of patients. And that's why we've got a breakdown for the COVID-19 patients between March 20 and January 21, where 2,651 patients in the organization tested positive for COVID, excluding those attended ED and went home from there. And we looked at among those patients, the 2,265 incidents that occurred across that time. Now, what it shows is that the distribution of incidents amongst this group of patients is very similar to the top 4 incidents in the organization at any given time across the NHS, actually, which is pressure ulcers or skin integrity, slips, trips and falls, infection control and medication incidents. Those are always been the top 4 incidents everywhere. And that's what it's looking at. Of course, all of these are looked at through the governance forum. So the pressure ulcers and falls go through the harm-free assurance care. Any grade 3 and grade 4 pressure ulcers or fractured long bones followed by a fall are major harm, and they are declared a series independently, and they are looked at through the series forum with a detailed RCA. And this separate analysis is specifically in relation to that ask. If we did a whole analysis for the entire patient group in the organization, it will look not very different, slightly different in that the COVID-19 patients were more likely to have had more pressure ulcers because of the proning and because of the various modalities of care offered in high risk respiratory wards and critical care. So I'll stop there.
I'll hand to Sam and then I'll check with Tony and then go back to Paula and Katie. Sam.
I think I was just going to expand a little bit on the pressure ulcers that the majority of our sick critical care patients spend 16 hours prone and ventilated, where apart from what we call swimmer's arms, where you are able to move their arms and sometimes move their heads, actually pressure ulcers on noses and ears and cheeks unfortunately became fairly unavoidable, although the team are very keen to lead and learn on having a lower incidence and a part of a research project with the wider Shelford group on preventing pressure ulcers in prone ventilated people. In terms of falls, I think there's no doubt as well that having no visitors in the hospital has a direct impact on ability to support people who might stand unaided and not be in direct eyesight of a nurse. So I think that they're the two key things I wanted to raise. We're also, through the COVID steering group, just re-looking at, with public health, the potential for reintroducing visiting in the coming weeks. So I just wanted to add that.
Thanks, Sam. Tony, has your question been answered or not?
Not quite, but it's along a similar theme. So, and this is, I think, again, for Megan and Sam, just looking back on falls and ulcers and so on, and we all know why we focus on these things. It's a sort of part of all the triangulation of things. There's a graph there which takes us back to August 2016, and the ulcers and so on have sort of been bubbling along that line up and down for 4 years, and I don't quite understand what the y-axis is, the percentage of all patients who come through, etc., etc. And I don't.
Tony, which page are you on? Sorry.
Let me just bring that up. 23 of the report itself. So, I don't quite know where we sit with everyone else, and that's the key. You know, we could be looking at that as a line, and in fact, it could be a brilliant result that compared to everyone else, because inevitably you're going to have ulcers for the reasons you've explained. We always want to avoid them. You're going to have falls, but I don't know where we sit with everyone, and also. I understand that when there are grade 3 and above ulcers, you know, there are processes which are put in place to learn and so on. But I wonder whether we need to rethink those, because the question we have to ask ourselves is, are they working? And inevitably, there's turnover of staff, they have to relearn, etc. But what we would hope to see is a gradual decline in these as a consequence of learning and intervention. So that's one thing. It's about that bundle of things, of ulcers and falls and so on. And the other one is around infection control and infection intervention. And I appreciate, of course, you know, we have been living through extraordinary times this past year. But I think it's worth going back before that to see if things really are very different, and what we should learn from how we are trying to intervene. And the last comment is just to ask Megan and maybe just to say a few words on the 2 Never events again, just to bring us back up to speed on that. So I'm sorry, that's a rather a long question and comment, but it's sort of got a similar theme that runs through it.
I didn't see who was first, Megan or Sam. So
well, I can start to answer certainly about infection control and never events, and make us start with the ulcers. But Sam chairs the harm-free assurance group, so I'll leave that for Sam. In terms of the never events, Tony, I think basically the pandemic has affected us in a lot of ways, and we can see that reflected in this report in terms of safety and quality of care. Both those never events, as discussed in IAC last month, were a direct reflection of the pressures on our staff and the conditions in which they were working during the pandemic. The first one, which was the wrong lung that was biopsied. There were lesions in both lungs. Left lung had an obvious neoplasm, and the right lung also had a dense opacity. And the practitioner, who is a very experienced consultant, said that there was so much pressure that she saw the obvious neoplasm on the CT scan and proceeded to biopsy that, because that's what she thought was required. Now, you know, the ask was actually to biopsy the other opacity, because the neoplasm was very clear to the operating team that that's what they were going to remove. So that was one, and that was completely actually environmental and human factors based, and the RCA will be ready to be presented to Bruno in a couple of weeks. The next one was again in EAU, and as Sarah has just said, EAU was transformed into a high-level care for COVID patients, completely at odds with the environment the staff is used to. The nursing care provided to patients was provided by our staff, who are not intensive care nurses, but they were trained, upskilled rapidly to provide care to these patients. And again, they were in full PPE, level 2 PPE. And, you know, the communication we know in level 2 PPE hasn't always been conducive to sort of making sure that everybody is getting exactly what they want, and we've reinforced that several times and tried different ways of communicating, increasing and improving communication when people are in level 2 PPE. And this was an incident where somebody asked for Actropid at the right dose, but the person who prepared it was outside of that area in terms of the level 2 care, and gave it in a 1 ml syringe instead of an insulin syringe, and that was administered. Now, neither patients have come to direct harm in terms of their care, but both these events, actually, when you look at the detail, it's very obvious to me that these have happened in highly pressurized, intense environments where staff were not in their normal way of working, as it were. In terms of infection control, again, we discussed C. diff and MRSA both. C. diff is above trajectory for the year and is on national inquiry and working with public health. Katie Jeffrey, our DIPSI, is very clear that it is linked to use of single-dose antibiotic regimes, so giving patients ceftriaxone or Cipro in order to prevent hospital admission out in the community. Patients with gallstone cholecystitis or appendicitis being given antibiotics rather than being admitted for surgical procedures has been on the rise, and this has contributed to increasing C. diff in the community. And the COHA, which is the community-acquired C. diff numbers, had gone up in the last 3 months. In terms of MRSA, again, we've discussed the need for again, environmental changes. So CTCCU had double the number of patients that they normally have, with bed spacing, which was very close, equally on AICU. And this meant that the staff, medical and nursing staff looking after these patients, who wear sessional gowns as PPE, could easily be transmitting these infections. Some people were double gloving as well, which is not recommended. We have, in response to this and in response to our analysis of infection control, come up with a 7-point plan, which looks at lines, tubes, devices, it looks at spacing, it looks at PPE, it looks at staffing requirements, and that's been circulated to all staff yesterday and will be reinforced at the staff briefing tomorrow. We've also got a study which has been done by a consultant in ICU, which actually does show that wearing half-sleeved gowns for PPE and single gloves actually reduces the infection. They did this as a simulated research study. And we are, Katie and I, we're going to have to take this nationally as to whether we should actually promote half-sleeve gowns with hand hygiene and gloves, single pair of gloves for all staff looking after these patients. Now, of course, I can't predict what's going to happen when our COVID numbers completely reduce and the bed spacing improves and people are not wearing level 2 PPE at all times, but clearly we still want to launch that 7-point plan for IPC so that we don't take any risks with regard to changing practice or people sticking to their practice as they've developed over the last year.
Thanks, Megan. Sam, and then I'm going to go to Sarah.
Just a couple of points. I think just prior to this second wave, we were about to set a divisional trajectory. So I agree with Tony. There is further improvements we can make, particularly around the area of medical device related pressure damage. This is an area that I think we've talked about before is just so difficult to benchmark. So even with real transparency with some of our colleagues, we know that our trust report everything, even less than 1 centimetre damage, whereas many other trusts don't report anything under 2 centimetres. We also report moisture lesions, etc., etc. But what I do think I have is more intelligent information that breaks down hospital-acquired, etc. And I would propose that I bring something within the IPR to IAC or maybe a separate briefing for next time, rather than kind of unravel where we're at now. And I've got a harm-free group on Friday, so we can certainly shape something for the board to break down this area of harm a bit more intelligently. The other thing that I think it's really important to add is just prior to working through our redeployment, we had to stretch our nursing ratios out fairly significantly. We undertook a quality impact assessment that was reviewed by Megan, Sarah and I, and through the COVID steering group, and we knew that we would have to accept a level of risk of quality of care to our patients by stretching out the ratios of staff that we had to care for patients with. So I think that's a very difficult thing for us to sign off. It's not unique to us, but we had to move out to some ratios that meant that we weren't able to provide the care that we'd normally afford to our patients to ensure that we could care for the amount of critical care patients that we had in the trust during the peak.
Thanks, Sam. So I'm not keen that we just add things into the IPR and look at them every month. So I think your idea of a brief to IAC and then IAC could decide whether or not there's a metric that it would be useful to integrate is the right next step from that. I hope you're happy with that, Tony.
Yes, I am, Jonathan. And just to pick up the one point I mentioned about going back as we did to 2016, it's maybe a piece of work going forward at some point would be to see how good our interventions are in terms of maintaining safety, etc.
Thanks. Sarah Horden, you are next.
Thank you, and thank you everybody for doing that COVID sort of almost mini deep dive. I really appreciate it. I think we've talked about it a lot. I think just in terms of if we were doing it again, what would have helped me would be to understand more about where this differed from the norm. So i.e. where are we over and above what we would expect to see in terms of pressure ulcers? I think it's come out really well in the conversation, but I think in the report being able to see this is what we'd normally expect from this number of patients. This is what we've seen with the COVID patients. Actually, we're over in these areas, and that's because of all the things we've just talked about would be really helpful as a reader. And the only other thing, just sort of picking up on Tony's theme, I just wonder there are some what's called SPC charts later in this report in the HR sections, which highlight really well where there's a statistically relevant change. And I just wonder whether those charts that Tony's looking at on page 23, whether we could look at getting those done as SPC charts for for the harm and pressure ulcers, and we might actually then, Tony, see where the real issues are popping out, as opposed to it's quite difficult to see whether it's just a bouncing along versus actually something shifted and we've got a real change for a period of time. And it would also help us ring fence the COVID issues for the future, because I suspect we'll see those COVID issues popping up quite nicely and then we should see them disappearing again.
Meghna.
Thank you, Chair. So, Sarah, absolutely, we had SPC charts every month for all the infection prevention and control metrics. Because of the change in case mix during the last year in terms of emergency and elective split, those have been stopped, but we will go back to reporting it as SPC charts once the activity resumes to be along the normal sort of elective emergency split. And in terms of benchmarking, there was I think a couple of IACs ago, Chair, there was a paper on benchmarking that I brought, or some slides on benchmarking, and it is Ria Betteridge, who is our lead nurse for pressure ulcers. She was very clear that there wasn't a benchmark available on NRLS for pressure ulcers, but we will be doing that going forwards for everything.
I think, thank you, Meghna. And I think what I was trying to say was against our norm. So understanding what the norm is for us versus what happened over the last 3 or 4 months. Sorry.
Thanks, Sarah. Thanks, Meghna. Could I ask just something about the harm review? So this is pages 38 and 39. And the two questions I have on that, one is there's a general statement on page 38 about the point that the impact of COVID has affected our ability to undertake individual harm reviews, but it doesn't really give a sense of how significant that impact is, either in terms of the number we're able to do or the risks that means that we're not cited on that we might otherwise be. So that's the first question. The second question, I only have two, just relates to the following page 39, which gives us a clear sight of a prioritization process, but it doesn't help us understand whether that prioritization process then feeds through into us treating the patients against that prioritization. So I would like to get some assurance on those two things, if I could, please.
Thank you, Chair. I'll start, and then Sarah and David will come in, I'm sure. So firstly, when the numbers for ENT run into thousands, it's really reliant and dependent on prioritization. So all the cases have been prioritized, and that itself includes an analysis of harm. That's how they're prioritized, whether they need surgery within 4 weeks or they can wait longer than 3 months to have it. So that's the first thing. So all of these cases have been looked at by clinicians in order to prioritize them. The problem is, and David will have to come in, is that the way the EPR was set up, it doesn't just change it. So if we say somebody is P2 or P3 and surgery can be delayed up to 3 months, at that 3 months plus 1 day, it doesn't just go, hang on, have these people now become P2, right? It requires somebody to look at all these 477 cases again, and that should not have happened. So David, I would appreciate if you could come in on that. And then the second thing was we still have the process, Chair, which we described last year for the 52-week harm process. So that is still being done. But what is not being done is we said we'd do it at 40 weeks. And given the numbers, we can't do it at 40 weeks. So we're reliant on the prioritization scheme.
Thank you. So there's still a significant amount, and it's still clinically led going on, but it's just more challenging. But the follow-through question is the trickier one from what you described. So David, you have an invitation.
Yeah, and I think the challenge that Meghna has articulated is quite correct, Chair. So the module that we deployed to allow this activity to undertake last year, in effect, does it as a static exercise. So that gives both the challenge with the timeliness, which Meghna has referred to, but also means that there's no dynamic updating of that initial prioritization based upon any deterioration of the patient over time. So there's nothing to inform the clinician that actually this patient has deteriorated. Some of the things initially have changed apart from the time indicator. So I'm in current conversations with the supplier to understand, one, is that we've just deployed it as a static module and it should be doing that? in which case, what do we need to do to change that so that it works much more effectively and with clinicians rather than as a burdensome administration exercise? And secondly, if it doesn't do that, then we need to find a solution which is much more seamless and simple for clinicians and for our staff to undertake. We can't be doing this each 3 months. So I'm having those conversations currently to see what good looks like. How have other people deployed this module? Does that meet our needs? And if it doesn't, then we will find something else.
Thanks, David. So I think that probably needs to be picked up in IAC to ask whether we can understand the progress on closing that loop. Sarah Randall.
So if I moved you slightly onto page 55, where monitoring of the patients that are being treated on the waiting list, I think, Chair, I think that was your second question, really, in part. So we are starting to monitor those patients. So I think it's, slide 55, where you can see P1 to P4 activity of the patients that have been categorized into those 4 different groups. So clearly we've been significantly challenged with our COVID response, and our focus has been actually treating the emergency patients and P2s, but we haven't been able to treat all P2s. So we do have a backlog of patients that need to be treated. So we are actually focusing on making sure we bring that cohort of patients within the 4 weeks of surgery. And also then starting the work on the P3 work. So the recovery program that we've talked about before is the P4 work, where we need to actually reduce those weights over 52 weeks. So so we're going to be monitoring that. So this is actually a new chart into the IPR, so we can actually monitor that categorization for board members. So I don't know whether that helps or not.
So it helps, Sarah, but there's still something I don't feel I've got quite a sight line in, which is that do we end up treating the people we prioritised in the order that we prioritised them and somewhere near the timetable that we think they need to be treated in, or is that remaining very challenging? So I think we've got good assurance on the fact that we're doing the prioritisation based on clinical criteria and what we should be doing for patients. I can't quite close the loop and see where I can understand that prioritization has also driven the treatment that they get, so that we are treating patients who do need to be treated earlier where possible. And I don't have any doubt about that being the intention. I just can't quite see how it feeds through into what's visible to me, and it may well be more visible in what you've had. So that's something I think for us to pick up in IAC to understand we can get assurance of that. I don't think we know a lot more about it than we did previously, but it still doesn't quite close the gap for me in my mind.
Well, certainly, I think we are more challenged at the moment because of the capacity where we redeployed staff and resources into the COVID response. So it's getting that capacity open. Yeah,
and I think the reason for worrying about this is because it's so challenging.
Absolutely.
If we don't prioritise the ones that we want to prioritise, then we may see us catching up with the wrong people. So it's just understanding that all this work going into prioritisation then just translate itself into the order in which people get treated. And as I say, it's a lot clearer to me than it was, but there's still a little bit of a gap between the good work being done on prioritisation and the assurance we have that that's how it translates into the treatment of patients. So I'm really grateful for seeing the extra slides, and it just prompts a few more questions. I apologise for that, but that is what we're here for as a board. And it doesn't belong to be solved here. It belongs in IAC to solve, but I think it's part of our job to flag it up. Those were my questions on the performance report. Are there any other questions on the IPR that we've not taken yet? I can't see any unanswered chat or hands. In which case, I think then we can move on to the constitution changes. there's quite a lot of detail, but I hope it doesn't require detailed discussion. It is important for us to get through in tandem with the Council of Governors, because any changes to the Constitution need to go through both the board and the council. And a lot of work has gone into this that we hope we've got right. And it is important we get it on the record, because should we wonder why we did things later on, this is our ability to go back and use as an aid to interpretation if we need it on the meaning of the Constitution. So Susan's done all the work, but Eileen, I think, takes the credit. I think that's the way it works, doesn't it, Eileen? And let you go first.
Definitely not, Chair. I just get to present it. I think, to be fair, Chair, my thanks to all colleagues for accepting such a long, detailed paper. But our constitutional review this is the first time we've reviewed it since we were actually authorised. So it is a complex piece of work. I think the thanks go not just to Susan and Neil and the team, but most importantly to our governors and the working group, ably led by Sally Jane Davidge, in helping us navigate our way through what are the time critical components of the Constitution that requires our consideration at this point in time. So this is the second phase of the items that were identified as being priority. And hopefully the paper provides you with a summary, but also sufficient detail to understand why and our rationale behind the proposals developed by the working group supported by the Chair and Vice Chair. Once we have received this approval today, if that's what the board decides, then it will go to the Council of Governors on the 31st of March, and then we will bring back the totality of the constitutional changes across the two phases to the board meeting in May and to the associated Council of Governors meeting at that time. And I would commend it to you for questioning or discussion. Susan has done all the heavy lifting with Neil and the governors, and I'm sure we will endeavour to answer any queries.
Thank you, Eileen. I've been over this so many times, I'm just going to throw it open to questions. I can't see any, so I think, Susan, that means it's an excellent piece of work that has gone through smoothly. The speed at which it goes through here is directly correlated with the care that's been taken to get it here, and it has been through a number of explorations with the relevant Governors Committee, and also some consultation processes through that. So I'm not surprised that people are comfortable with it, and I'm very grateful. And I think that means that we can agree those changes. Well done, Susan.
Thank you very much, everyone. Thank you.
Thank you. So that then takes us to the medical education annual report, and I haven't seen whether Claire has joined us yet.
She is, Chair. She has.
So in that case, do you want to introduce it, and then Claire can make any comments before we throw it open?
Thank you, Chair. So this is the annual report on postgraduate medical education, and it's been an exceptional year for junior doctors, both trainees and also locally employed doctors that we have in OUH, which are actually 300 of our junior doctor workforce is locally employed. We have, as you know, extensively redeployed medical trainees during the first wave and the second wave. And I have to say, we made sure in the second wave that we took all the learning we had from redeployment in the first phase and made sure that there was a regular review in terms of redeployment, which was led by Annie Sykes with Claire and Deborah Harrington and a few others, and made sure that the trainees obviously were all risk assessed, and HEE had their own RAG rating about who could be redeployed and to which areas. So all that was done really well. We also know that because of COVID, training duration is going to be extended in as many as 50% of trainees for the craft specialties like general surgery or obstetrics and gynecology. So that is going to that's going to need to be managed, and Claire will have the detail on that. Another thing we did during COVID is move to completely virtual induction. And that has been, from my point of view, that has been good and bad. Good, given that there's a lecture, it's on tape, and people can just hear me. Not so good because I don't get to see them. And I hope we can introduce that, because it used to be wonderful to see the junior doctors, and Bruno and I used to speak to all the new starters once every 6 to 8 months, but also I used to do the induction every month. So something about that we could have a sort of a mixed approach going forwards. I will let Claire say any further detail or answer any questions that anyone might have. Thank you, Chair.
Thank you, Meghna. Claire.
Thank you. I just want to make a couple of brief observations. It's a long report because a lot happened. Just to say some real positives. COVID has made us all work in a very different way, more agile. We're using Teams, we're using WhatsApp. We're connecting with our learners and our trainers in a different way. And that's been really helpful to us, I think. Historically, from the assurance point of view, the backbone of this report has been the GMC survey, but actually the GMC survey now is the last full survey relates to what happened in the training year 2018 to 19. So what we're moving to now is much more collaborative, local intelligence, hearing about problems and sorting them out sooner. And I think that's a real positive. And just to give you the headline, which is in here, so for as long as I've been here, so 7-8 years, we have been on the GMC enhanced monitoring for our neurosurgery. We received the letter just a couple of weeks ago that we are off enhanced monitoring. And I asked HEE to review everything that's on the education risk register, and we have currently no red risk rated educational issues in the trust. So although assurance isn't all that we do, I think that's, we're at a moment in time where the direction of travel has been to improve things. So we're in a good place now. Of course, it's unrealistic to expect that we'll never have any more red risks, but actually what the plan now is that we hear about things early and we respond to them quickly and we sort them out locally. We don't have things that go on and on and on for years. And I just want to thank Meghna, particularly, but everyone on the board. I think we've changed our relationships with trainees and learners. We've had lots of open meetings during COVID. We've had open Q&As. We've increased our number of educational supervisors from 400 to 500, so people are starting to get engaged in this. The next year is going to be really challenging, picking my adjective there. We've got a lot of things to do to get people back to being productive and effective and happy and safe and well post-COVID, but we're going to link in really closely with everything. We don't want to do something different for trainees. So whatever the trust is putting on for all its employees, we'll put on for trainees. And I think we've got some other interesting pieces of work around workforce transformation. But we are in a good place, which is the culmination of year-on-year improvements. And we can start to do some developmental work now. Thank you.
Thank you very much, Claire. The other Claire Flynn, had her hand up, so I'll move to her.
Thanks for a very comprehensive report, Claire. I actually enjoyed going through the indicators at the back of the report, and it was interesting to note that there were sort of wide variations in things like supportive environment between different specialties. Mm-hmm. I sort of have two questions. One might be for Terry, and I think the other one is for you. Do we look at this and correlate it with other data that we have about our departments so that we understand in the round, how things are for staff? That might be the Terry question. And for you, when we sort of see what I think the cultural issues being reported back by our trainees, sort of how do we go about dealing with those when they're challenging?
So the answer is yes, we do. But it's the timeline with the GMC report is the survey is done in the spring, and people then put into that survey everything that happened in the previous year, and then we don't get the results until the summer, and then the action plan isn't until the following spring. So that is why I'm quite keen to move away from the GMC survey as it's not a real-time reporting tool. So it's useful for historical context and direction of travel, and I often find it very useful. We're not the only place that's got reds. So we're developing lots more local intelligence tools, and they happen through us, through the trust, through departments. Most departments have what what would be called a local faculty group, but they will have different names here. So, you know, someone in the department thinks about education and feeds up, but how we pull all that into a network is a challenge for this year, because it happens in different ways in different departments. And then for trainees, that also happens at the regional level. So they would feed through programme directors and heads of school, but they report to the region. I'm really keen that we think about the learning environment for everyone. So not just what the trainees are saying to HEE, but what all the learners in the department, both trainees and trust doctors, and also the wider department, so other professions. So that's a piece of work that we've not really, we're starting on, but we've spent the past 2 or 3 years has been, can we get out of this GMC enhanced monitoring? Can we turn our red risk areas? Can we reduce those risks? So now we're in a position where we can really focus on progressing that learning environment conversations. And just as an example, you know, some things have come up this year, 2 or 3 things, just that the whole accessibility and the agility of the reporting pathways. People are telling us about problems that we can fix before they ever get anywhere near a register. We're having meetings with departments. So Rob, Stuart, and thank you also for Magna, really pushing forward exception reporting, not as a stick, but as a real-time reporting. This is what's going on. We can hear about something and get in quickly. But there's more we can do, and we will be doing that this year.
Thanks, Claire. I've got Meghana and then Tony after Meghana.
Thank you, Chair. I think Claire's partly answered my question, and that was about Claire, you asking about, you know, how do we go about looking at other indicators, and we absolutely do. So we know that in clinically busy environments, trainees require more support. For example, SEU, so Surgical Emergency Unit, and Claire and I have been managing that alongside Giles Bond Smith, you know, regularly, and we sort of talk to the trainees, and then we talk to Giles. We make sure there is a mechanism for trainees to interact with Giles and all the senior surgeons, and we look at the ward environment as well. And we have changed things in the last year in a number of specialties based on closer and more prospective interaction with different groups of staff at a very local level. And I think the same has applied to oncology as well. So that very much happens, so that there is an overview. I think Terry might be able to say more, but I mean, I'll answer on behalf of Terry too. There is an overview of what's happening, and there are various sources of information. So there's the Guardian of Safe Working report, there's the Junior Doctor Forum, there's the sort of trainee surgeries, there's the old GMC report, but there's also the LNC, where there are junior doctor trainee representatives. So all of that comes together, Claire.
Yeah.
So I'm going to abuse Chair's privilege and add a sort of half question to that before I go to Tony and let Terry answer. And that's the one that jumped out for me is clinical oncology, where you could see that ophthalmology was challenged but moving in the right direction, but clinical oncology is going in the wrong direction. And I wanted to understand what we thought about it from this, but more importantly, the point about where does this sit with other things that we know.
Yeah.
And the governance question behind that really is how, through our board committees, do we ask ourselves the question, what does this add up to? So I'm minded to think we need to hear something about clinical oncology at IAC. So if you can add that to the...
well, I can tell you now, Chair, and we won't need to...
Go ahead, and then Terry can gloss on that, and then I'll go to Tony.
So basically, clinical oncology is about a very specific thing where oncologists feel they shouldn't be participating in the general medical on-call rota. And this is a specialty specific thing. And we worked, again, what you see is from 2 years ago. So we worked on this, and oncology has a completely different rota pattern now. We've recruited 2 more doctors. They're out of the hospital at night rota. And James Gilbert, who is a renal transplant surgeon, has worked extensively with Claire and myself in sorting all this out. So actually, this won't be a problem going forwards. And there is no other cultural or service issue in oncology.
That's very good to hear. Terry, were you picking on the back of that, and then I'll go to Tony?
Yeah, it's just about the further governance. And Meghana mentioned a number of items where it's all of these issues are picked up, but there's also the Workforce Committee, which both Claire and Rob go to, and we look at all of the issues together. they highlight whether there's a specific issue that affects our juniors in a specific area, and we look to see what the other issues are around what the staff survey data is saying in that area, around what the issues are that are coming up from other staff groups, and see whether there's an issue. And so that's mainly where those issues are picked up, and where we have develop a response to that as well.
Thanks so much, Terry. Tony, you've been very patient. You'll go now.
Thanks, Jonathan. It's a question about undergraduate medical education. I don't expect an answer now, but this is often another useful part of the network of information about how well certain specialties are working in all sorts of different ways. And it would be helpful at some point to understand what the medical students say about the different firms. Gavin may be able to help on this, but I mean, OUH presumably has a sizable contract for doing this, and it's probably helpful at some point to hear. I just see Jason shaking his head whether it's sizable or whether we have.
The university has the undergraduate contract.
I beg your pardon?
The university has the contract, Tony.
Okay, but but OUH.
We have
subcontracted to provide medical education.
And you're absolutely right. And I have often wondered why there isn't an undergraduate medical education report. So I do meet with Catherine Swales, who is the head of undergraduate clinical studies, regularly. But you know, over the last 2.5 years that I've been here, there hasn't been a report. Doesn't mean we can't. And I mean, I suppose I'm happy to discuss it further with Gavin as to what he thinks and how we can make it happen.
So we should distinguish, Megan and I think, the sort of accountability type annual report that which we receive because we have oversight, from the clinical governance benefits of having feedback from people, which would be very useful to have. That's prompted Claire to come in. I will invite Gavin to make any comment he wants to after Claire.
Just say very briefly, I also meet regularly with Catherine Swales in her Director of Clinical Studies role. And one of the questions I always ask is, you know, which departments are great, which are less. So we're triangulating because it's the same issues. I'm meeting with her next week to see if we can develop this a bit more.
Thank you. Gavin, is there anything you want to add to that?
Thanks, Jonathan. I don't seem to have a hand function, but I don't have much to add to that. I mean, Catherine is clearly the person with her hand on the rudder here. So I actually haven't had that conversation with her for a good while now, and it's prompted me to actually have that the next time I meet up with her.
Thank you. So I think we should take from this that the board would find it useful to have the triangulation that could come from that intelligence, and that presumably also applies to nurse education, and working out whether there is a mechanism for using it to triangulate with other data we have to help us understand hotspots would be useful. I think it belongs with IAC rather than the main board, so perhaps we could take that way to think about how we get it in. Claire.
Really quick one. Health Education England have introduced yet another national survey, the NETS survey. It's for all learners, so it would encompass undergraduates and other healthcare professions. I put a link to it in the report, but the data is just, we can't drill down enough the numbers of people doing it, and quite frankly I think people have got survey fatigue, so that will be a useful national overview, but I'm not sure how useful a local tool it is. At the moment this year, the most important tool has been people talking to each other and people being able to WhatsApp directly, you know, WhatsApp messaging me directly, having dedicated inboxes for people to give feedback. So I think next year we'll have a bit more structure and a bit more information to tell you about that. That's great. No, we have plenty of data points in this organisation, and we don't want to stop ourselves analysing things by just collecting more, but there is something about asking ourselves what is available. But I think that's for IAC rather than here. So we'll take that as something to reflect on. It's been useful to have it out of the medical education report, and it's, as usual, prompted lots of thoughts, and we'll take that forward. But the key business is that we receive Claire's report, and I think we've done that, and that's been very helpful, and I am going to move on unless anybody stops me.
Okay, so we then have the regular reporting items which we just need to note. The first is IAC, which is mine as chair. As usual, almost everything that we pick up from there has come up already on the agenda. I'd just like to draw attention, as Bruno did, to the mutual aid that the Trust has provided to other parts of the NHS during the COVID pandemic to date, and that was picked up as part of our discussions of COVID at IAC. We also had discussions around C. diff and around harm reviews, as we've had today, and we looked at a number of aspects of the Ockenden review, as we have done today. So the only bit missing for that is the discussions of the forecasts of revenue and capital, which you'll see are noted there. And Jason has got off lightly in terms of financial discussions in the public board, but I'm very confident that when we get to private board questions, we'll have plenty of time with Jason, as many of the decisions board needs to take are commercially sensitive and the like and can't be taken here. So those are the things just draw the board's attention to around IAC. And if there are any questions, happy to pick them up, but I suspect most of them were asked earlier in the meeting. Thank you. The next committee is the Audit Committee, and Paula assures me that she had nothing particularly she wanted to draw our attention to, which is a relief, because she's having connection problems as her building work is going on, as well as headache, I suspect, problems with the background noise. So I think I'm just going to invite you to note that, unless Paula wants to say anything more than she thought she did.
No, I'm good, Jonathan. You might hear some banging in a second, but to be honest, it was very much a prep for the year end as well, going through a whole lot of issues. And the next report will be more fundamental.
Thank you very much.
Actually, I would actually just like to say the one thing that we did observe was the way that the assurance team have kept going throughout the pandemic. And I think that's just a really important point to make for the board. We made it in the audit committee. The reports that we are used to receiving, we continue to receive. And I think that's a real credit. And we will focus again on those. Obviously, in some details, we've got a little bit more headspace now. But things like the BAF, the risk register, I just do think it's worth reassuring the board that that's been ongoing. I know I'm definitely going. You don't want to hear any more from me.
Thank you very much, Paula. When these things are reported in Hansard, and you get brackets laughter at the end, we'll have, in the minutes, it'll say brackets drilling or something of that sort in the background. Paula, we're amazed at your ability to stay paying attention despite all of that. I don't think, though, I see any hands up in relation to the Audit Committee report. And the final one is the Trust Management Executive TME report. And I'm not sure there are any questions that want to be raised from that, Bruno, unless you want to speak to it.
Just highlight two items, Jonathan. One, maybe for the history books, but the West Wing ventilation project is completed. And I just want to remind the board that this was a tremendous effort. And want to thank Sarah, but many other people who were instrumental in finishing those works. And the second one is that we're all used to online board meetings by now, but we're also doing online welcome events for our new staff, which we're trying to also make a great virtual experience with. And I know a number of us have done videos, and those will be used for the online welcome. And then maybe finally, before we close on that report, a number of the TME decisions that were mentioned in that report are coming later on the board agenda as well. So we'll be able to discuss those capital projects, mostly around refurbishments and equipment purchases that are more than £1 million.
Thank you very much, Bruno, but all tend to be commercially sensitive and therefore belong in the part 2 business. And the final paper is on consultant appointments and the signing of documents or non-signing of documents. And I think that brings us to the end of our public session, unless there's other business that I have missed. Neil, have I missed anything?
No, I'm not aware of anything further, Chair.
In which case, if people are content, we will pass a resolution to exclude the public. It's a technical thing that we do, but we'll pull the public session to an end and take a bit of a break before we restart the private session of the board at the scheduled time. We may be nearing the ability to contemplate board meetings in physical places again, but I'm keen not to rush that, as with the roadmap, until we know that we can do it sustainably. So I'm grateful again for everybody for managing with Teams, for our 3 governors who've joined us, but there will be many more who are watching this. And I think I'm grateful we've had a good set of discussions on some tricky questions, and with that, get yourselves a little bit of a break and possibly some lunch, and we will reconvene at the scheduled time for part 2. Thanks very much, everybody.